Hey guys, welcome back to DOCSHAALA. So in this video of case-based scenarios today, we are going to see about basal cell carcinoma from the subject oral pathology. So what is a basal cell carcinoma? I think most of you have come across this basal cell carcinoma in your undergraduation, and it is a really very important uh, topic. So let's just see it in brief now. So basal cell carcinoma, as you know, it arises from a sun-damaged skin. So it arises from sun-damaged skin, and it rarely develops on mucous membranes of palms or soles. Okay, and it is a slow-growing tumor, in which the metastasis is rare. Okay, and it can be highly destructive and disfigure the local tissues when treatment is inadequate or delayed. Okay, then coming to the pathophysiology. So what is the mechanism behind this basal cell carcinoma formation? Because we don't know whether everybody of us is exposed to sun, but does every sun damage cause this basal cell carcinoma? No, it is only caused due to ultraviolet radiation. When this ultraviolet radiation from the sun comes and causes direct DNA damage or indirect DNA damage in the patient, then only there are chances of developing a basal cell carcinoma. So how this direct or indirect DNA damage occurs? Through radioactive oxygen species and immune suppression. So these are the main key factors which help in formation of basal cell carcinoma. Then melanin, what we have a melanin content. So everybody of us have melanin content. We have melanin in our skin, in our hair, in our eyelashes, eyebrows, everywhere we have melanin, which are the pigment cells that are present in the skin and its allied tissues, right? So when melanin absorbs UVA type of ultraviolet rays and causes indirectly damage to the DNA through free radicals, then only this basal cell carcinoma occurs. Then UVB directly damages the DNA and RNA with characteristics connective tissue or connective tissue transition. Okay, then ultraviolet exposure also causes dose dependent suppression of the cutaneous immune system. Cutaneous immune system is nothing but that is on the surface, okay, impairing immune surveillance of skin cancer. Okay, then coming to the histopathology. So histopathology of basal cell carcinoma is very important. You have to remember this no matter what. So the characteristic feature for the characteristic feature for this histopathology is islands or nests of basaloid cells. So islands or nests of basaloid cells with cells palisading at periphery in a haphazard arrangement in the centers of the island. So islands or nests of basaloid cells with cells palisading at periphery in haphazard arrangement is the characteristic feature of basal cell carcinoma. So each of these small pleomorphic cells is composed of a basophilic nucleus without discernible nucleolus or scanty cytoplasm. And retraction artifact or clefting is seen. So retraction artifact or clefting is seen between the tumor and its surrounding stroma on paraffin embedded sections. Okay, mucin deposition may be present within the tumor and in the stroma surrounding the tumor. Okay, mitotic figures may also be present. Perineural growth or perineural invasion can be an indicator of aggressive disease. Okay, so this is how a typical basal cell carcinoma occurs. So you can see a lot of basaloid cells being appeared in this image itself, right? So all the cells are basaloid with little or scanty cytoplasm and discernible nucleolus, and clefting is seen, right? So there are morphological subtypes of basal cell carcinoma. So what are the morphological subtypes? Let's just see. So there are many types. So they have listed here. It is nodular, micronodular, superficial, cystic, infiltrating, infundibulocystic, pigmented, adenoid, sclerosing, metatypical, basosquamous, fibroepitheliomatous, and mixed patterns. Okay, so you can just remember these by their morphological appearance. But we have certain specific important morphological subtypes we should remember. I'll just discuss only those in this video now. So superficial basal cell carcinoma, by the name itself, you can say that it is superficially affecting the skin. So as you can see the image, so it looks like a superficial crusting of the skin, right? And in the histopathology also, there is only small buds of basaloid cells from the epidermis with no dermal invasion. Dermal invasion cannot be seen. Okay. Then coming to nodular BCC. So nodular BCC, as you can appreciate from the image, it appears as a nodule. Okay. So it is a majority of cases which we see are of nodular BCC only. Okay. So they are composed of islands of cells with peripheral palisading and a haphazard arrangement of more central cells. So islands of cells with peripheral palisading is seen here, right? So ulceration may be present in larger lesions. Okay. Then coming to micronodular BCC. So what is the difference between nodular and micronodular is that in nodular BCC, we have a single nodule which is of appreciable size. In micronodular BCC, we have that nodule in which we have multiple nodules, micronodules like this, right? So this is like this. Then, so similar to the nodular subtype, it has, but the basaloid structures are divided into multiple nodules. Okay, as you can appreciate. Okay, the micronodular has much greater risk of local recurrence than the solid type. Then coming to sclerosing BCC, so it is looking like a vitiligo patch, right? But this is a basal cell carcinoma. So it is composed of spiky basaloid thin strands of cells that invade the dermis surrounded by dense fibrous stroma. So you can appreciate the image here. So the thin strands of cells are being seen, right? So they invade the dermis, spiky thin strands of cells are seen. So when most of the tumors have spiky projections, the tumor may invade deeply, referred to as infiltrative BCC. Okay. Then coming to pigmented BCC. So this is very easy to identify, right? So pigmented BCC, it has melanocytes and melanin admixed with the tumor cells. So which is more common in the superficial type, micronodular type, and also in follicular variants of BCC. So you can appreciate the pigment here and also in the histopathological image here. Then coming to infundibulocystic BCC. What is infundibulocystic? The cysts are in the form of a fundal, that is like a drop appearance. Okay, so that is called as infundibulocystic. So it is uncommon and is often found around face. So the variant is a small, well circumscribed tumor composed of nests of cells arranged in anastomosing manner with little stroma. Okay, numerous small infundibular cyst-like structures containing keratinous material and sometimes melanin can be seen. So in this image, you can see the melanin, right? And these are the small infundibular cysts. So it is appearing like something like what we say, flask type cysts, right? So this pattern is called as antler pattern. So this is important. Make a note of it. Infundibulocystic BCC appears in the form of antler pattern. Okay. Then coming to basosquamous or metatypical BCC. So in this, both features of basal cell carcinoma and as well as squamous cell carcinoma can be seen. Okay. That is, the cells, both of the basal cell layer and squamous cell layer are affected. The exact nature of this lesion is very controversial, but most reserve this term for the rare basal cell carcinoma composed of nests and strands of cells maturing into larger and paler cells without peripheral palisading. So it is looking like this, right? Then coming to Fibroepithelioma BCC. So it presents as a soft nodular lesion resembling a fibroma or papilloma that is commonly seen in lower part of the back. So it is commonly seen in lower part of the back. So it is composed of anastomosing strands and aggregates of basaloid cells surrounded by fibrous stroma. So this is a soft nodular lesion, as you can see. I've not got the histopathological picture, so if you have to share it with me, so that we can share it with other people also. Then management. So management, how we do? So no single treatment is ideal for all patients. So a biopsy should be taken when there is a suspected BCC to confirm the diagnosis and also to confirm the histologic subtype. Then the main goals is to remove the tumor to prevent recurrence at a later date and to correct any functional impairment which the tumor is causing, and to give best cosmetic result to the patient, because it occurs mostly on face and all. So the patients are mostly concerned with the cosmetic appearance of the face after the removal of the lesion. So that also should be we should take care of that also and achieve that. Okay. Then coming to a clinical scenario now. So a tanned 66-year-old male presents with an ulcerated lesion on the nose. Okay, so ulcerated lesion on the nose, so just imagine how the pain of that man will be. Okay, so with a rolled edge, the incisional biopsy revealed nests and cords of cuboidal cells with palisated appearance of peripheral neoplastic cells. The most likely diagnosis will be, so the rolled edge is seen in basal cell carcinoma. Okay, we didn't discuss this. I've only discussed only about, mostly I've concentrated on histological subtypes, but a rolled edge is seen in, rolled edge ulcerated lesion is seen in basal cell carcinoma. Then coming to the histology, and in the biopsy we see nests and cords in palisated appearance, so in BCC. Okay, so the correct answer will be basal cell carcinoma. Okay. So if you like our video, do subscribe to our YouTube channel. You can also follow us on our Instagram handles at DOCSHAALA for dental content and at DOCSHAALA medical for medical content. You can also follow us on our Telegram. Thank you and see you again in the next session.